Welcome to Global Dispatches, a podcast about foreign policy and world affairs. I'm your host, Mark Leon Goldberg, editor of UN Dispatch. And in this show, we discuss topical global issues, have conversations with foreign affairs thought leaders and newsmakers, and give you the context you need to understand the world today. Go to globaldispatchespodcast.com to learn more. And now on with the show. Getting bitten by a poisonous snake is not just an individual injury. Rather, it is now recognized as a global health hazard. In fact, the World Health Organization estimates that between 80,000 and 136,000 people die from snakebite each year. To put that in perspective, that is more than the number of people who die from meningitis and within the range of the number of people who die from measles. Getting bitten by a poisonous snake, or as it is known, snakebite envenoming, is now included in the World Health Organization's list of neglected tropical diseases. On the line with me today is one of the world's leading experts in snakebite, Dr. Gabriel Alcoba. He is a pediatrician who has treated snakebite as a doctor with MSF, or Médecins Sans Frontières, Doctors Without Borders. He is also a public health expert who works with the Geneva University hospitals. This episode provides a very good introduction to snakebite as a global health problem. You will learn a lot from this episode. I know I did. I came into this episode probably like you with very little information about snakebite. I did not even know the term snakebite envenoming. But I left this conversation with a much clearer understanding and appreciation for how and why snakebite ought to be considered a global health challenge. As regular listeners know, I often use this podcast to shine a spotlight on undercovered global issues, and I think this certainly fits the bill. Let me know what you think of this episode. You can hit me up on Twitter at Mark L. Goldberg or reach me via email using the contact button on globaldispatchespodcast.com. I do love hearing from you and hearing what is on your mind. And now here is my conversation with Dr. Gabriel Alcoba of MSF and the Geneva University hospitals. Have you ever been bitten?
No, luckily not. I've been very close to a king cobra in Myanmar, Burma, which was very impressive. A 3-meter king cobra, which is practically the largest venomous snake and one of the most dangerous. It was close. I was coming out of a temple. I was barefoot. And I just had time to go into the car, and all our colleagues were shouting, King Cobra, and the King Cobra disappeared. But I've seen a lot of patients, unfortunately, in the hospitals in South Sudan, in Agok. We're working in a large hospital in South Sudan that receives about 400 snakebite victims every year, especially during the snakebite season. It's a bit like malaria. It's during the rainy season. And also in Myanmar and Nepal, we're working very hard, in Cameroon as well. Yeah. So, and in every country, the patients present in a different way. And, yeah.
Can you just tell me the story of a patient that you've treated in, say, South Sudan?
Yes. So in South Sudan, I treated a little young boy, about 3-4 years old. He presented with his father, and his father described this little black snake that had bitten him during the night, and his face started swelling, and he was nearly choking. Actually, the swelling was really, really large around his face. Luckily, in those days, we had a very polyvalent anti-venom that was quite effective, and luckily the swelling reduced and he didn't choke. His respiratory airways were protected, didn't die. Few days later, a young girl, 12 years old, I think. Yeah, 12 years old, arrived. She was still talking, and she had some red tears, and suddenly she collapsed and she died of a hemorrhagic shock. And this was likely due to a carpet viper, which is one of the most dangerous vipers in Africa. That cause hemorrhagic shock and coagulopathy. And in Myanmar, I saw quite a lot of Russell viper victims, which is the most common and deadliest snake in Myanmar. and they present. Some of them presented without a toe. Most of them were bleeding, especially in the urine, and they present a kidney failure. So this is a very special type of impact. Most of them are neurological, hematotoxic, cytotoxic. That's really the skin swelling and necrosis and amputation. But there are also other presentations like kidney failure and other presentations. Some cobras are spitting cobras, so they can spit into your eyes and blind you for some time. Luckily, it's not permanent if you do something, if you clean it quickly. So it's a very diverse problem, snakebite.
Can you describe the problem of snakebite, its sort of impact, and just kind of maybe run through some numbers if you have them?
Yeah, of course, absolutely. Snakebite actually is the consequence of an interaction between humans and snakes, just to make it very simple.
Mm-hmm. That's a good definition. It's as pithy a definition as one might expect.
Yes, exactly. It's very simple. Then we often see that it's caused by humans going into the snake territory, and snake usually don't bite humans. Snake usually bites small animals, rodents, frogs, lizards that they eat, and they also help us balance the ecosystem in terms of pests like preventing typhus and plague and other diseases. Then we talk about snakebite envenoming. In fact, the current WHO term is snakebite envenoming, and all the policies are about snakebite envenoming.
How do you spell that? I've never heard of that term.
Snakebite envenoming. Some people talk about snakebite envenomation as well, but in most recent literature, we speak about snakebite envenoming. The vast majority of victims are envenomed by venomous snakes, of course. It's very obvious, and very few die from non-venomous snake bites. And in fact, snakes are found on all continents, from Australia to Sweden, and not only in tropical areas, and often the consequence of a high contact between humans and snakes. And where risk factors are very common. And risk factors are often linked to poverty, but not always. But some of the typical ones are being barefoot, some types of habitats, some types of farming, flooding, displacements, very often linked to demographics and poverty and density of population and density of snakes. Not only diversity of snakes, but also density of snakes.
So do we know rough? So the World Health Organization collect rough estimates of the number of people, for example, who are killed by snakebite envenoming?
Exactly. So the current estimations are about 5 million people being bitten every year, and of those, about 2 million are envenomed. And actually, between 80 and 136,000 die every year. On top of that, we estimate about 400,000 people plus are disabled or amputated due to a snake bite. So this is quite a huge burden.
Can you maybe put that into context in terms of how that compares to other kind of disease burdens around the world?
So roughly, we're talking about 100,000 snakebite deaths. And this is very comparable to very severe epidemics of measles, meningitis, and much more than Ebola every year, which is something quite impressive, actually, when you put it in perspective. And it also is mainly affected very impoverished people, so they have a kind of a double burden, and that's why we talk about neglected tropical diseases. It's always affecting the poorest of the poor, voiceless communities, the most remote communities most of the time, and very often rural, not urban, so not visible, not rich, not influential.
That's interesting. I just want to emphasize that basically the number of people who are killed by snakebite each year is roughly equal to the number of people who die from measles every year.
Depending on the estimates, measles is a tiny bit more, possibly around 200,000, but it's comparable. The current estimates of snakebite are between 80 and 136,000, but it could be beyond that. And this is absolutely comparable, and it's more than the current meningitis estimates. Meningococcal meningitis is killing less than 100,000. And actually these two diseases are really coming down thanks to vaccination. Thanks to the huge efforts, despite some rebels around the world.
Yeah.
We've seen fantastic successes in terms of reduction of measles, meningitis, and other vaccinable infectious diseases. Whereas snakebite has never been considered as an infectious disease. It's not an infectious disease, and it has never been really tackled as a tropical disease by the whole international community. It has always been considered as a neglected tropical disease, and we've been advocating very much for the past, let's say, 20 years. Our group has been very involved, and now personally I've been very involved for the past 5 years in really raising the awareness, not only about snakebite, but also about the lack of anti-venoms and the lack of adequate anti-venoms.
So, it's often said that like neglected tropical diseases are diseases of poverty. And, what's interesting to me is like snakebite on the one hand almost seems like it's a disease of like accident, right? Like you accidentally, come into contact with a snake that bites you and you get your leg amputated off. It's sort of like a chance occurrence. But what you seem to be suggesting to me is that there are kind of like structural factors that increase the chances of that happening. And
Absolutely.
Poverty is like one of those structural factors. Like if you don't have shoes, and you step on a snake, chances are you're more likely to be, envenomed by that snake if you're not wearing shoes.
Yes,
can you, I guess, like talk about some of those structural factors that increase the risk of individuals from like dying or being severely harmed by snakebite, and maybe like just talk through some like examples from around the world based on your own research and your own experience?
There are quite a few examples within our research group, and I currently work in Cameroon, in Nepal, in South Sudan, and really, some of our colleagues have published very interesting data on structural factors that really are risk factors for snakebite. And it includes not having a mosquito net. It includes not having rapid transport to get to the closest hospital that has antivenom. And actually, the odds ratio in studies by Professor Chapuis and Sanjeev Sharma in Nepal have really showed very high odds ratios for not having rapid transport, not having mosquito nets. And other studies have showed, and all our studies have showed that being barefoot is a risk factor because most of the bites are on the foot. Depending on the country, it's between 60 and 80% a bit on the foot, the ankle, or the lower part of the lower limbs. So it's quite structural, quite related to structural issues. It's also related to the fact that hospitals have not been provided antivenom, but also that the training to tackle snakebite, which is a scary emergency, has not been provided in medical school or in nursing school or at community health worker level. In most of these Asian and African countries that are the most affected, simply because it's not really part of the curriculum in many of these trainings, despite the fact that it creates a lot of death and disability and including PTSD, also psychological impact. So I think there's also a kind of taboo related to that. That's I think it's a scary topic that people are not always ready to talk about, and it's also a little bit linked to the fact that the pharmaceutical industry has not invested so much, and that's so if you don't have a good product to tackle the snakebite, you cannot really feel very efficient. So it creates some frustration amongst clinicians and also us. I mean, amongst us as Doctors Without Borders, working in the field, and our colleagues also, Geneva University hospital projects. Really, it's very frustrating sometimes not to have the perfect product that you can use to treat all the snake bites.
So what are the products?
It's multifactorial, actually.
Yeah. So
as I said before, really to summarize, it's affecting the poorest of the poor, often very remote communities, often rural, often not visible or influential, and it doesn't travel to the north either. It's not like Ebola that creates a huge scare because it's infectious, contagious, and travels by plane or to the north to richer countries. So it can be a bioterrorism threat, etc. And this is quite a hidden catastrophe in the remote areas. As I said, the investment by pharmaceutical industry, but also partly also the academics and the donors in general haven't invested enough.
Yeah, I mean, I'm speaking to you from a region in the United States that does have snakebite, has rattlesnakes, and and there's I went hiking, last year, and in that same path, someone was bitten and died from a rattlesnake. Yeah. And so, it does affect everywhere, but presumably the healthcare system we have here in, Colorado is, stronger and the hospitals are stocked with the proper anti-venom.
Yeah, but even in Colorado, I mean, to my knowledge, snake antivenom is extremely expensive. It could cost you up to $10,000. If you're not insured, it's a catastrophic expenditure. It's also a problem in the US, even if you have few tenths of deaths per year. It's also a huge problem. It's not. There's no equality. I think this is a very universal problem. The cost of antivenom, the access to antivenom, is very, very difficult.
So let's talk about that. Is the access to antivenom the sort of reason that people who are bit, say, in Nepal or in Cameroon, where you work, die? Is it as simple as that?
Absolutely not. It's not as simple. It's a very complex issue. It's multifactorial, and it's an accumulation of disasters. It's the factors that I said before in terms of structural problems, but it's also a question of product quality or product effectiveness or clinical efficacy, potency of the product, and cost of the product, and also toxicity of the product. Some products are very well designed and are absolutely effective against a wide range of snakes, and in some countries we have very good products that are covering all the snake venoms, so they can neutralize all the snake venom. So in some places it's not a question of quality. In other places it's a question of quality, simply because they're produced from equine serum, from horse serum. So then it has to be purified, fractioned, but you're still injecting a horse product, which is similar. I mean, let's say that it's also the case for rabies or for tetanus or for diphtheria. These antitoxins are quite have quite a few side effects, like anaphylactic shock, but also serum sickness. These are side effects that can be potentially deadly.
So what are some of the policy solutions that could significantly reduce this burden of death and disease from snakebite? I mean, it sort of sounds like a lot of the solutions that you're sort of hinting at in terms of better quality of medicine is something that's very similar to other neglected tropical diseases. It's just a situation where you have, like, pharmaceutical companies don't see incentive to create quality medicines because it's not a big moneymaker for them. It's not
Absolutely.
Because the people who are sickened by this are not wealthy, and just like in general, like globally, like not a lot of people are sickened.
Yes, so I think for the moment, snakebite is seen as a relatively complex challenge. and this was the case until recently, and we were very happy to welcome WHO's initiative and all the member states that started working on the roadmap. And this snakebite envenoming roadmap is practically a reality now. There is a strategy and it just needs to be implemented. In some places, as I said before, the situation is extremely complex because you have multiple snake species which create multiple different types of syndromes. You know, some of them cause just swelling, necrosis, and shock. Others cause coagulopathy. You can bleed to death, and others paralyze you. So in some places, it's a question of recognizing which type of symptoms you have, and then you can adapt the anti-venom, because you know that if you are paralyzed, it's a cobra, for instance, and you can use the anti-cobra anti-venom. In other places, it's much more complicated because several species can cause several overlapping syndromes. So that's one of the things. In other places, they have polyvalent antivenoms that cover all the species. And so I think for those, the strategy is quite straightforward. And one of the main topics are, one of the main objectives are to accelerate access to antivenom, access to training, access to good epidemiological data, to be able to map the hotspots, because it's quite patchy sometimes, and to support member states, government institutions, academic research, and pharma industry to have perfect access to adequate antivenom. In other sides, in other countries, I think the strategy will not be as easy. It will be hindered by many, as you said before, structural problems, but also by conflict. Unfortunately, some of the countries where we see a lot of snakebite are conflict countries, like currently, like in South Sudan, like in Central African Republic, like in Yemen. We are seeing a lot of snakebite victims. So in those countries, it will take not only medical research and medical efforts and medical policy, but it will be a much more global policy. Then, so the roadmap currently states to accelerate global efforts and provide coordination to control snakebite envenoming. So that's very broad, ensuring quality and safety of antivenoms and other treatments, and prioritization of high impact interventions. This is, let's say, the strategy. And then you have others that are very, very important as well in terms of technical cooperation, exchange of data between institutions, research institutions, to make everything a bit open access, to have common methodologies to measure snake bites. Very few maps exist. We are currently working on mapping snake bite because very few countries have been completely mapped, and it's not like measles, meningitis, HIV, or Ebola, where it's one disease with one pathogen. Here we're talking about several diseases, in fact, paralysis, the hemorrhagic shock, etc., and several snake species, and hundreds of snake species. And having a common policy for all of that demands quite a multidisciplinary team. We're also working on One Health approach, including veterinarians, ecologists, people who really understand the behavior of snakes and the impact on animals who are also bitten. So this gives you a little bit the flavor of all the problems, and it's also an economical problem. So some people just go into debt because they've been bitten by a snakebite, or one of their family members has been bitten, has lost a limb, or has died, and then they cannot work. They're losing all the salaries. So this is quite a multidisciplinary approach.
It's sort of like like as you said, it's interesting that it is now more and more becoming like part of the vernacular of global health is snakebite and snakebite envenoming. Whereas previously it really wasn't seen as like a global health issue. But I think for all the reasons you describe, it's becoming, a little bit more in sort of the mainstream of global health professionals.
I also see it as a huge challenge because we are facing a multi-pronged problem. And luckily, I think we are very happy now because WHO has done a fantastic work on the roadmap, also working on evaluating new antivenoms. There is an ongoing evaluation of antivenoms to one day to have a real pre-qualification system for all antivenoms, so to have a kind of quality control for all of them. And then we hope that WHO will implement as well, with the help of partners, maybe like us at Doctors Without Borders and Global Snakebite Initiative and other partners, to work on a common stockpile or a revolving fund. There are different policies to provide antivenom. Like in Latin America, they have it for vaccines, the PAHO system, where there is a common purchase of vaccines, and this reduces the price. And also the providers, the producers themselves, can foresee in advance, let's say 4 or 5 years in advance, so they have a big stockpile, so it's much cheaper to produce.
And that's like a pretty common strategy for
it's a common strategy,
for diseases that are like neglected, that are effective for you have like these kind of group purchasing power.
Exactly. So I was mentioning the Latin American project, let's say purchase system, which is in fact quite sustainable, but each member state has to pay a certain fee to purchase this. In other countries, and I'm thinking of conflict-affected countries like South Sudan, Central African Republic, and others, for the moment, I think it's maybe a little bit complex, and we are also looking at other types of system like some revolving funds and sponsored stockpiles, where emergency organizations like International Red Cross, MSF, and ICRC and others are participating to having this common stockpile with WHO and UNICEF, and to provide it in case of emergencies. And in some cases, we are seeing snakebite emergencies. Like epidemics, like the one I witnessed in South Sudan in 2014. It was practically a real epidemic. We were seeing 3 patients per day. And in Kenya, currently, there's one in Baringo State, and we saw quite a lot of snakebites all of a sudden in Central African Republic and Ethiopia among farmers. We would like to understand a bit better how to predict this, to have real models, and this is part of my work with my research team at the University of Geneva on predictive models, predicting snakebite hotspots with satellite imagery, several layers, the ecology, the human density, the human activity, etc., to have something much clearer, to read, to focus, to target, like some other groups have done for other neglected tropical diseases like schistosomiasis and other parasites. Sleeping sickness, etc.
Well, Gabriel, thank you so much for your time. This was very helpful, and I came into this conversation with like very low information about snakebite, and I didn't even know the term snakebite envenoming until we talked. And I've learned a lot from you. I suspect those listening have as well. So thank you.
These medical terms are changing all the time. Yeah. All right. Thank you very much. Thank you very much for your interest and your time.
All right. Thank you all for listening. Thank you to Dr. Gabriel Alcoba. That was absolutely fascinating. I did not know much about snakebite going in, as I said, and now I feel like I have a pretty decent grasp of why it ought to be considered a global health issue. One last request, please do leave a review of the show on iTunes if you have not done so already. It's a great way of helping to increase the exposure of this show among people who are looking for foreign policy and world affairs show. If you do leave a review on iTunes, let me know. You can send me an email to let me know that you have left a review, and I will send you a sticker in the mail if you're in the US or Canada, or I will send you some digital goodies as a thank you. All right, we'll see you next time. Bye.